This is from MedSurg Timby, Chapter 28, Caring for Clients with Heart Failure. Learning Objectives. Discuss the pathophysiology and etiology of heart failure. Distinguish between acute and chronic heart failure. Identify differences between left-sided and right-sided heart failure. Describe the symptoms, diagnosis, and treatment of left-sided and right-sided heart failure. Discuss the medical and nursing management of clients with heart failure. Discuss the pathophysiology, etiology, symptoms, diagnosis, and treatment of pulmonary edema. Discuss the medical and nursing management of clients with pulmonary edema. The heart is a double pump. Cardiac function. The heart is a double pump. The right side pumps deoxygenated blood to the lungs for oxygenation, and the left side pumps oxygen-rich blood into the systemic circulation. This process provides a continuous supply of oxygen and nutrients for cellular metabolism and a mechanism to eliminate carbon dioxide and metabolic waste. Disturbances in one part of the heart, if they are severe or sustained, eventually affect the entire circulation. This chapter discusses the pathophysiology of heart failure and the medical and nursing management for clients who develop it. Heart failure is the inability of the heart to pump sufficient blood to meet the body's metabolic needs. An estimate of the heart's efficiency as a pump is its ejection fraction, the percentage of blood the left ventricle ejects when it contracts. Normally, a healthy heart ejects 55% or more of the blood that fills the left ventricle during diastole. As the heart fails, the amount of ejected blood decreases. The heart's ejection fraction is measured using an echocardiogram or multiple gated acquisition scan. The term congestive heart failure, CHF, describes the accumulation of blood and fluid in organs and tissues from impaired circulation. Types of heart failure. One way to classify heart failure is by how it develops, acute or chronic. Another way to classify it is by location, right-sided or left-sided. Acute and chronic heart failure. Acute heart failure is a sudden change in the heart's ability to contract. It can cause life-threatening symptoms and pulmonary edema. Chronic heart failure occurs when the heart's ability to pump effectively is gradually compromised and its impaired contractility remains prolonged. The New York Heart Association further classifies chronic heart failure based on the amount of activity restriction it imposes. There are 4 functional stages of chronic heart failure are as follows. Class 1 is mild. Ordinary physical activity does not cause undue fatigue, palpitations, or dyspnea. The client does not experience any limitation on activity. Class 2 is also mild. The client is comfortable at rest, but ordinary physical activity results in fatigue, heart palpitations, or dyspnea. Class 3 is moderate. There is marked limitation of physical activity. The client is comfortable at rest, but less than ordinary activity causes fatigue, heart palpitations, or dyspnea. And then there's class 4, which is severe. The client is unable to carry out any physical activity without discomfort. Symptoms of cardiac insufficiency occur at rest. Discomfort is increased if any physical activity is undertaken. The American Heart Association and the American College of Cardiology also use criteria to describe 4 stages of heart failure. The scale ranges from stage A, in which there are no current symptoms, but the client has 1 or more risk factors such as hypertension or diabetes that predispose to heart failure, to stage D, in which there is advanced structural heart disease and marked symptoms at rest, despite maximal medical therapy. The 2 classification systems differ in that there is no comparable class in the New York Heart Association classification for stage A. Left-sided and right-sided heart failure. Because the heart is a double pump, it is possible for either the left or right ventricle or both to become impaired. Again, left-sided and right-sided heart failure. Because the heart is a double pump, it is possible for either the left or right ventricle or both to become impaired. The term left-sided left ventricular heart failure and right-sided right ventricular heart failure describe the location of the pumping dysfunction. Left-sided heart failure results from various conditions that impair the left ventricle's ability to eject blood into the aorta. Right-sided heart failure occurs when the right ventricle fails to eject its diastolic filling volume into the pulmonary artery, causing congestion of blood in the venous vascular system. The major cause of right-sided heart failure is left-sided heart failure. Chronic obstructive pulmonary disease, COPD, also contributes to the development of right-sided heart failure. Pathophysiology and etiology. Two mechanisms can cause heart failure. The primary reason for failure of either the left or right ventricle is inability of the heart muscle to contract because of direct damage to the muscular wall. Myocardial infarction usually affects the pumping ability of the left or right ventricle and frequently contributes to acute heart failure. Acute heart failure may immediately follow an MI or develop sometime after the initial episode. The second mechanism occurs when the pumping chambers enlarge and weaken, as in cardiomyopathy and hypertension, making it impossible for the ventricles to eject all the blood they receive. Left-sided heart failure. When the left ventricle fails, the heart muscle cannot contract forcefully enough to expel blood into the systemic circulation, which is cardiac output. Blood subsequently becomes congested in the left ventricle, in the left atrium, and finally the pulmonary vasculature. This fluid accumulates and creates congestion in the pulmonary vascular bed, which is the capillary network surrounding the alveoli. Increased pulmonary vascular bed pressure causes fluid to move from the pulmonary capillaries into the alveoli. Gas exchange is impaired, cells become hypoxic, which is a state of insufficient oxygen, and CO2 accumulates in the blood. Hypertension, tachyarrhythmias, valvular disease, cardiomyopathy, and renal failure can contribute to chronic heart failure. These conditions reduce cardiac output by increasing afterload or systemic vascular resistance. Afterload is the force that the ventricle must overcome to empty its diastolic volume. Increases with arterial hypertension, aortic stenosis, pulmonary hypertension, or excessive blood volume from renal failure. Reducing ventricular ejection volume because diastole, during which the ventricle fills with blood, called preload. Is shortened as a result of tachyarrhythmia, causing a loss of elasticity in the muscle as a result of cardiomyopathy. Also, age-related vascular changes can contribute to heart failure by interfering with the blood supply to the heart muscle, thus causing the heart to become fatigued. Various levels of compensation may be required owing to a variety of factors that contribute to narrow and inflexible vessels. In review, the pathophysiology of left-sided heart failure is afterload, the force that the ventricle must overcome to empty its diastolic volume. It increases with arterial hypertension, aortic stenosis, pulmonary hypertension, or excessive blood volume from renal failure. Also, you could have left-sided heart failure from reduced ventricular ejection volume and loss of elasticity in the muscle as a result of cardiomyopathy, which is enlarged heart. Right-sided heart failure. When right ventricular failure develops, the right ventricle cannot forcefully contract and push the blood into the pulmonary artery. As a result, the congestion of blood and backflow accumulate first in the right ventricle, then in the right atrium, the superior and inferior vena cava, and subsequently the venous vasculature. MIs that affect the right ventricle can also cause right ventricular failure. Clients with chronic respiratory disorders tend to develop right-sided failure as a consequence of cor pulmonale. Cor pulmonale is a condition in which the heart, which is called cor, is affected secondarily by lung damage, which is called pulmonale. Pulmonary disease impairs oxygen exchange and carbon dioxide exchange, leading to increased CO2 in the blood. By an unknown mechanism, pulmonary arterial vasoconstriction occurs. Prolonged pulmonary arterial vasoconstriction results in pulmonary hypertension, which is elevated pressure in the pulmonary arterial system. With pulmonary hypertension, the right ventricle is forced to pump against a high pressure gradient. Then the right ventricle enlarges and weakens under the increased workload, leading to failure. When the right ventricle fails to empty completely, blood is trapped in the venous vascular system. Eventually, the fluid is forced to move in retrograde fashion into the interstitial spaces and cells of other organs and tissues of the body. Compensatory mechanisms. The body can compensate for changes in heart functions that occur over time. When cardiac output falls, the body uses certain compensatory mechanisms designed to increase stroke volume and maintain blood pressure. These compensatory mechanisms can temporarily improve the client's cardiac output, but ultimately fail when contractility is further worsening. As cardiac output falls, the clients become hypotensive. The low blood pressure stimulates the sympathetic nervous system to release catecholamines, like epinephrine and norepinephrine, to raise the heart rate and the blood pressure. The increased force and contraction of the heart, maintain the client's blood pressure, but increase the need for myocardial oxygen. This is the amount of oxygen the heart needs to perform its work. Epinephrine also causes blood vessels to constrict in an effort to raise blood pressure. As the sympathetic nervous system is stimulated, the body shunts more blood to the vital organs of the brain and heart, decreasing blood supply to the kidneys. The kidneys secrete renin in response to decreased blood flow, which initiates the renin-angiotensin-aldosterone system, RAAS. Renin activates angiotensin. Angiotensin causes vasoconstriction and increases blood pressure. Angiotensin also stimulates the adrenal gland to secrete aldosterone, a hormone that causes retention of sodium and water to increase blood pressure by increasing the amount of blood returning to the heart. Sensing an increase in fluid pressure within the heart, the ventricles secrete a neurohormone known as beta-type natriuretic peptide, BNP. BNP is cardioprotective. Its function is to decrease the blood pressure by increasing the excretion of sodium and water and promoting arterial dilation. It achieves its effects by counteracting renin, angiotensin, and aldosterone. But ultimately, if compensatory mechanisms fail to restore homeostasis, the client's status is compromised by increased blood volume that the heart must pump and overwhelming the resistance the heart must overcome from arterial constriction. As cardiac output falls, the body's cells become deprived of oxygen and switch from aerobic metabolism to less efficient anaerobic metabolism. Anaerobic metabolism results in accumulation of lactic acid, which lowers blood pH and can eventually cause metabolic acidosis. Assessment findings. The severity of symptoms depends on the body's ability to adjust to the decreased cardiac output. Initial signs and symptoms reflect the ventricle of the heart that is experiencing dysfunction. Usually when a client has chronic heart failure, he or she develops signs and symptoms of both right-sided and left-sided heart failure. Box 28.1 on page 474 in your book highlights the clinical differences between left-sided and right-sided heart failure. Left-sided failure produces fatigue, paroxysmal nocturnal dyspnea, meaning you can't sleep and you have to sit up to breathe. Well, orthopnea does, which is one of the symptoms. Hypoxia is not enough oxygen, crackles in the lungs, cyanosis, S3 heart sound, a cough with pink frothy sputum, elevated pulmonary capillary wedge pressure. In right-sided failure, you have weakness, ascites, which is fluid in the abdomen, weight gain, nausea and vomiting, arrhythmias, elevated central venous pressure, and jugular vein distension. Pharmacologic considerations. Ask about history of cancer treatment during the intake assessment. Cardiac toxicity may develop in cancer survivors who are treated with chest radiation or chemotherapy drugs, such as adriamycin and vincristine, which is Oncovin. Chemoprotective agents such as Zinacard are now used to reduce cardiac adverse effects. Left-sided heart failure produces hypoxemia as a result of reduced cardiac output of arterial blood and respiratory symptoms. Many clients notice unusual fatigue with activity. Some find exertional dyspnea, effort at breathing when active, to be the first symptom. Inability to breathe unless sitting upright, orthopnea, or being awakened by breathlessness, which is paroxysmal nocturnal dyspnea, may prompt the client to use several pillows in bed or to sleep in a chair or recliner. The pulse may be rapid or irregular. Blood pressure may be elevated from sympathetic nervous system stimulation. A cough, hemoptysis, blood-streaked sputum, and moist crackles on auscultation are the typical respiratory findings. Urine output is diminished. If acute left-sided heart failure with pulmonary edema develops, the client suddenly becomes hypoxic, restless, and confused. Early symptoms of heart failure in older adults can present differently than in younger adults and include fatigue, confusion, anxiety, dyspnea on exertion, worsening renal function, or other comorbidities. Right-sided heart failure. The client with right-sided heart failure may have a history of gradual, unexplained weight gain from fluid retention. Dependent pitting edema, which is excess fluid volume in the interstitial space in body areas affected by gravity, such as the feet and ankles, can be observed by pressing into tissue over a bone for 5 seconds and then releasing the pressure. The pressure forces fluid into the underlying tissue, causing an indentation that slowly disappears. This type of edema may seem to disappear overnight, but really is temporarily redistributed by gravity to other tissues, such as the sacral area. Fluid may distend the abdomen, called ascites, and the liver may be enlarged, called hepatomegaly. Jugular veins often are distended from increased central venous pressure. Enlarged abdominal organs often restrict ventilation, creating dyspnea. Clients may observe that rings, shoes, or clothing may become tight. Accumulation of blood in abdominal organs may cause anorexia, nausea, and flatulence. Diagnostic findings for left-sided heart failure. Chest x-rays show cardiac enlargement and fluid accumulation in the lungs. An echocardiogram can reveal the increased size of the left ventricle and ineffective pumping of the heart. A multiple gated acquisition scan, called MUGA, is also called a gated blood pool scan, measures a decrease in the ejection fraction. An MUGA scan is the most accurate non-invasive test that measures a multiple gated acquisition scan, also called gated blood pool scan, measures a decrease in the ejection fraction. An MUGA scan is the most accurate non-invasive test that measures the left ventricle's ejection fraction during rest and activity. When an MUGA scan is performed, the client receives an injection with IV radioisotope that concentrates within the red blood cells in approximately 20 to 30 minutes. A gamma camera can identify the cells once they are radioactive. The client is then attached to a cardiac monitor, and the gamma camera takes images as the blood passes through the heart and major blood vessels. The client must lie very still at intermittent times during the 45-minute test. Diuretics are contraindicated the morning of the test to avoid any interruptions for urination. Clients also are medicated to relieve a cough that may cause movement during the test. Although the allergic reactions to the IV chemical can occur, they are rare. At first, the arterial blood gas (ABG) analysis may reveal respiratory alkalosis as a result of rapid, shallow breathing. Later, there's a shift to metabolic acidosis as gas exchange becomes more impaired. Serum sodium levels may be elevated. Elevated blood urea nitrogen indicates impaired renal perfusion. If the client is seriously ill, a pulmonary artery catheter may be inserted for hemodynamic monitoring. Cardiac output can be measured with the pulmonary artery catheter. Cardiac output is diminished in left-sided heart failure, and pulmonary artery pressure and pulmonary capillary wedge pressure measurements are elevated. The BNP levels are above 100 picograms pg. Question: an elderly client has had a myocardial infarction of the right side of the heart. Which of the following signs should the nurse anticipate when assessing for heart failure? A. Nausea. B. Heart murmur. C. Crackles in lungs. Or D. Edema in feet and legs. The answer is D. Edema in feet and legs. With right-sided heart failure, blood backs up in the systemic circulation, causing swelling of the lower extremities. Right-sided heart failure. A chest x-ray, an EKG, and echocardiography reveal right ventricular enlargement. A lung scan and pulmonary arteriography can confirm cor pulmonale. Liver enzymes are elevated if the liver is impaired. Medical management of both left and right-sided heart failure is directed at reducing the heart's workload and improving cardiac output, primarily through dietary modifications, drug therapy, and lifestyle changes. A low-sodium diet is prescribed and fluids may be restricted. Activity is limited according to the condition's severity. Sedatives or tranquilizers reduce dyspnea and relieve anxiety. In acute or worsening heart failure, a device for resynchronizing the heart's contraction or an intra-aortic balloon pump that provides mechanical circulatory support may be used to support left ventricular function. Drug therapy. Historically, medication protocols for heart failure and used cardiotonic drugs such as digoxin. One issue of this therapy was the narrow therapeutic range of this class of drugs and the toxic adverse reactions. Currently, medications prescribed for hypertension, such as angiotensin-converting enzymes, ACE inhibitors, angiotensin receptor blockers, ARBs, diuretics, and beta blockers, are the mainstay of heart failure drug therapy. However, digoxin use continues for older clients maintained on the drug for many years. People who continue to experience symptoms after using the first choice of drugs, in some cases to treat atrial fibrillation, which is also decreasing. A newer cardiotonic replacing digoxin, IVA-BRA-DINE, blocks the IF channel and inhibits the pacing of the SA node of the heart. This in turn slows the heart rate and allows blood to fill the heart chamber. Recent studies demonstrate the use of a combination drug of sacubitril and valsartan together, which reduces mortality and hospitalization owing to heart failure better than ACE inhibitors alone. Sacubitril, which is a neprilysin inhibitor, interferes with an enzyme that metabolizes endogenous vasodilators, while valsartan, an angiotensin receptor blocker, works better than other ACE. Cardiac resynchronization therapy, CRT, is a new technique that restores synchrony in the contractions of the right and left ventricles. CRT is used primarily for clients whose heart failure is caused by dilated cardiomyopathy. It is achieved with a biventricular pacemaker. The biventricular pacemaker is inserted transvenously, similar to a traditional pacemaker, with electrical leads in the right atrium and right ventricle and the battery placed beneath the skin of the chest. It has an additional internal third lead, however, that is placed outside the left ventricle. The dual ventricular leads stimulate the right and left ventricles to contract at the same time. When the ventricles contract simultaneously, the force of contraction improves and more blood is ejected with each heartbeat. Cardiac resynchronization. The purpose of a biventricular pacemaker is resynchronization of the heart. This intervention is used to treat advanced heart failure that does not respond to medication. The purpose of defibrillation is to stop a life-threatening ventricular dysrhythmia. Intra-aortic balloon pump. If cardiogenic shock accompanies acute left ventricular heart failure, an intra-aortic balloon pump may be used. An IABP acts as a secondary mechanical circulatory pump to temporarily supplement the ineffectual contraction of the left ventricle. It is inserted as a catheter into the left femoral artery and threaded up to the descending aortic arch. The IAPB is connected to a machine that inflates the balloon portion during ventricular diastole and deflates during systole, a process known as counterpulsation. Inflation of the IABP increases coronary artery, renal artery, and myocardial perfusion. Deflation actually keeps the aorta distended so that cardiac output is improved. The work of the left ventricle is decreased and peripheral organs are more adequately perfused with oxygenated blood. The IABP is intended for only a few days' use. Which of the following client teaching points should be included in the discharge planning of a client who's had heart failure? Choose all that apply. A, weigh yourself daily. B, take your blood pressure again before taking digoxin. C, increase your carbohydrate intake. And D, take your diuretic early in the morning. The answers are A and D. Weigh yourself daily and take your diuretic early in the morning. The client can assess any fluid retention by weighing daily. The client should also take the diuretic in the morning to decrease the chance of nocturia, which is getting up in the night to urinate. Surgical treatment. When medical treatment alone is unsuccessful, clients may require surgical treatment options such as the insertion of a ventricular assist device, cardiomyoplasty, or an implantable artificial heart. Ventricular assist device, VAD. There are approximately 870,000 people who develop heart failure each year. Of those, 50 to 100,000 usually in the class 3 or 4 of heart failure have refractory heart failure. Refractory heart failure refers to symptoms of heart failure that persist despite maximum medical therapy with proven efficiency for managing heart failure. Many with refractory heart failure experience disease progression, repeated hospitalizations, and may ultimately succumb to death. Some clients with refractory heart failure who meet specific criteria are candidates for interventional therapies like a VAD, ventricular assist device, an auxiliary heart pump that supplements the heart's ability to eject blood. If the VAD supports left ventricular function, it is referred to as a left ventricular assist device, or LVAD. VADs may be used for one of three purposes: a bridge to recovery, a bridge to transplant, or destination therapy, mechanical circulatory support when there is no option for a heart transplant. When a VAD is implanted, the natural heart remains in place and continues to function at whatever capacity is possible. Most VADs use an outflow and inflow cannula to carry blood from the left ventricle into the aorta. They are battery operated through an external power source worn about the waist. By assisting the weak, ineffective left ventricle, VADs maintain cardiac output at normal volumes. Some VADs act as a double assist device that can be used for left-sided, right-sided, or biventricular heart failure. The trend is to develop miniaturized devices. One current model weighs only 3.25 ounces. Companies are now working on LVADs that can be implanted with less invasive surgery, with a potential survival rate of 2 years, with fewer complications such as bleeding, strokes, and a decline in cognitive function. Clients can easily manage smaller models, making it possible for some to return home and continue a functional life or await heart transplantation. Cardiomyoplasty is a surgical procedure in which the client's own chest muscle, the latissimus dorsi, is grafted to the aorta and wrapped around the heart. An electrical stimulator placed in a subcutaneous pouch triggers skeletal muscle contraction. The contraction acts as a counter pulsation mechanism similar to the IABP. It adds to the ineffective myocardial muscle contraction force. A ventricular containment procedure, sometimes referred to as a heart wrap, may be performed. In this procedure, a polyethylene polyester support mesh device, which some have likened to pantyhose, serves as an alternative to the cardiomyoplasty procedure. The heart wrap is pulled over the heart and sutured in place. The wrap supports the heart and reverses ventricular remodeling, a condition in which there are changes in the size, shape, structure, and physiology of the heart after a heart attack. This procedure may be an alternative to a cardiac transplant. Ventricular restoration. A procedure known as surgical ventricular restoration, SVR, decreases the size of the heart to a near normal size and shape by removing dysfunctional heart muscle that does not contract properly. Once the adynamic, non-functioning area is removed, the ventricle is repaired with a patch. Other procedures such as mitral valve replacement or coronary artery bypass graft can be performed while the heart and chest are still open. In the cases that were studied, 91% were free of congestive heart failure after surgery, with an ejection fraction that increased from 30 to 40%. Total artificial heart, TAH, is an electrically powered pump that circulates blood into the pulmonary artery and the aorta, thus replacing the functions of both the right and left ventricles. It is considered an extension of LVADs, which only support a failing left ventricle. TAHs are targeted for clients who are unlikely to live more than a month without further intervention. Currently, there are 2 TAH models: SynCardia's CardioWest TAH and Abiomed's AbioCore TAH that are available as a bridge to transplant or destination therapy. When implanted, the TAH replaces the functioning of both ventricles of the diseased heart, including the 4 heart valves. Although both TAHs achieve similar outcomes, there are several differences. As technology in developing artificial hearts improve, they may eventually become an alternative to human heart transplantation. Nursing management. Most clients can manage chronic heart failure at home. Many medications, lifestyle changes, and diet restrictions are involved to control heart failure. During times of acute illness, usual methods may not control symptoms, and the client may require hospitalization for additional treatment. The home health nurse, the nurse in an extended or intermediate care facility, and nurses in acute care settings administer prescribed medications and monitor for therapeutic and adverse effects. They implement interventions that promote the heart's ability to eject as much blood as possible, monitor for signs of excess fluid volume, and evidence of electrolyte imbalance. They promote oxygenation, balance activity according to the client's tolerance, and support family members who may be the usual primary caregivers. Question. A client may be at risk for impaired gas exchange related to pulmonary congestion, secondary to left ventricular dysfunction. A nursing intervention to assist clients with maintaining adequate gas exchange includes all of the following except maintaining client in a high Fowler's position, administering supplemental oxygen, limiting physical activity, or providing foods and beverages that are a good source of potassium. Providing foods and beverages that are a good source of potassium. Dietary intake of foods and beverages that are rich in potassium affect serum potassium levels secondary to diuretic therapy and is not related to maintaining adequate gas exchange. Cardiogenic pulmonary edema. Pulmonary edema is fluid accumulation in the lungs, which interferes with gas exchange in the alveoli. It represents an acute emergency and is a frequent complication of left-sided heart failure. Cardiac arrhythmias and cardiac or respiratory arrest are associated complications. The following discussion focuses on cardiogenic pulmonary edema, which develops as a result of heart disease in general and heart failure more specifically. Non-cardiogenic pulmonary edema, also referred to as acute respiratory distress syndrome, develops when a pulmonary embolism, infection, or blast injury alters the pulmonary capillary membrane. Pathophysiology and etiology. In cardiogenic pulmonary edema, the left ventricle becomes incapable of maintaining sufficient output of blood with each contraction. The right ventricle continues to pump blood toward the lungs, however, and the left ventricle has difficulty emptying. There is retrograde fluid accumulation in the left atrium and pulmonary veins. The pulmonary capillaries and alveoli become engorged with blood. The lungs rapidly fill with fluid and acute respiratory distress develops. As CO2 accumulates, respiratory rate and depth increase. Without treatment, hyperventilation becomes insufficient to prevent respiratory acidosis. Metabolic acidosis follows. Assessment findings. Clients with acute pulmonary edema exhibit sudden dyspnea, wheezing, orthopnea, restlessness, cough, often productive of pink, frothy sputum, cyanosis, tachycardia, and severe apprehension. Respiration sounds moist or gurgling. If a pulmonary artery catheter is in place, the pulmonary artery and pulmonary capillary wedge pressures are elevated and cardiac output is reduced. While the body responds with arterial vasoconstriction, it may temporarily sustain adequate blood pressure. However, the client eventually becomes hypotensive and peripheral pulses disappear. Chest x-rays show pulmonary infiltration with fluid. ABGs indicate severe hypoxemia, which is a low PaO2, hypercapnia, which is a high PaCO2, and a pH below 7.35. Medical management. Because pulmonary edema can be fatal, lung congestion needs to be relieved as quickly as possible. Supplemental oxygen or mechanical ventilation is used to support breathing. Inotropic medications, which improve myocardial contractility, are administered to relieve symptoms. If the cause of heart failure and pulmonary edema can be corrected surgically, such as a mitral valve disorder, the client is supported medically while being prepared for surgery. Oxygenation. To facilitate gas exchange, oxygen is administered. A mask rather than the nasal cannula is needed to deliver the maximum percentages of oxygen. If respiratory failure occurs, the client is intubated and oxygen is administered under continuous positive airway pressure or with mechanical ventilation with positive and expiratory pressure. Drug therapy. Inotropic agents such as dopamine, inotropin, dobutamine, Dobutrex, and amrinone, which is Inocor, or digitalis, are administered IV to improve the force of ventricular contraction and improve renal perfusion. To reduce myocardial oxygen consumption, drugs that reduce venous return to the heart, such as diuretics, and promote vasodilatation, such as nitrates, ACE inhibitors, calcium channel blockers, are prescribed. IV morphine sulfate often is given to lessen anxiety. Morphine seems to help relieve respiratory symptoms by depressing higher cerebral centers, thus relieving anxiety and slowing respiratory rate. Morphine also promotes muscle relaxation and reduces the work of breathing. Invasive measures. If the client does not respond to drug therapy and oxygenation, additional interventions such as the insertion of an IABP, biventricular pacemaker, or LVAD are used to sustain life. Cardiomyoplasty, use of an artificial heart, and subsequent heart transplantation are further treatments. Nursing management. Effective resolution of pulmonary edema requires both medical and nursing management. The nursing diagnoses, interventions, and expected outcomes for clients with pulmonary edema are similar to those with clients experiencing heart failure. Clients with pulmonary edema need close assessment in an intensive care unit. The nurse establishes an IV line immediately for medication administration. Because of the severity of symptoms and respiratory compromise, the nurse administers IV diuretics and inotropic agents and monitors the therapeutic and adverse effects of medication therapy. Bedside EKG monitoring is standard, as are continuous pulse ox and automatic blood pressure and pulse measurements every 15 to 30 minutes. Critically ill clients who are hemodynamically unstable may have a pulmonary artery catheter inserted to measure the pressure readings in the heart chambers and to estimate cardiac output. A urinary catheter is inserted to evaluate response to diuretics. The nurse assesses for proper placement and adherence of electrodes and ascertains that electronic monitoring equipment is functioning properly. The client receives oxygenation to maintain normal blood gases. If the client requires mechanical ventilation, the nurse suctions the airway as needed, provides frequent mouth care, and establishes an alternative method for verbal communication. Typically, clients are monitored for hypokalemia when diuretics are used for rapid diuresis. Be aware that ACE inhibitors are potassium sparing, and therefore symptoms of hyperkalemia should be monitored if these drugs are administered too. This is the end of the slideshow.